Hello, everyone. Thanks for joining us today for Medicaid Managed Care, an overview for SSAs. My name is Joe Russell, and I'm the Policy and Advocacy Director for the Ohio Association for County Boards. I'm joined today by Adam Herman, the OACB's Communication Director. He's going to be handling the tech side of things. We also have with us Chris Wolf of TIL Consulting, who is working with OACB on all things managed care. We also have Matt Costello, who is the SSA for Guernsey County Board of DD. He's also a registered nurse. Finally, we have a few people here representing Ohio's Medicaid managed care plans. First, we have Christine Day from Molina. She's a Medicaid care manager. We have Natalie Hicks from Paramount, who is a senior regional outreach coordinator. We also have Kim Knieven from UnitedHealthcare Community Plan, and she is a health services manager. The primary purpose for today's webinar is to provide SSAs with basic information about managed care in anticipation for questions that you might receive from families and individuals on the topic. As you may already know, on January 1st of 2017, people with developmental disabilities will have the option to enroll in Medicaid managed care or continue with their state plan Medicaid card services. Although this new option does not change in any way, shape, or form your role and responsibility as an SSA, we expect that this new option may generate lots of interest with individuals and families you serve. More importantly, we expect that those individuals and families will undoubtedly turn to you for answers to their questions. So, we want to ensure that you have the information necessary to answer any questions that you might receive from your caseload, or in the very least, know where to turn to find those answers.
So in front of everyone, we should see the agenda. I'm not going to go bullet by bullet, and you've probably had enough time to look at it for a little bit and see what we're going to cover. There is a lot to cover. I think we'll get through it all and get through it well. Hopefully we'll have some interaction. We've been talking to the plans before today or before this presentation, and so hopefully get some engagement with them. And we also have an SSA here, Matt, that we're going to be bringing in to really talk about that SSA role and sort of what it might mean to him. But let's go ahead and get started. So our present day, let's cover this relatively quickly. Up to this point, I think everyone recognizes what we have for our populations that we work with, those specifically on waivers or on ICFs. We have state plan services. I'm not going to go into anything extensive about that. Just understand it is the norm. It is the typical. It is the now. It is the paper card. It is the any willing provider. What we hope to do today is contrast how state plan services are different and the same, if you will, as managed care plans. And that's really going to be critical in trying to understand and make the decisions that's best for the individuals. There was a budget bill that was passed in June of 2015 that made way for all of this to happen. It basically will allow that come January 1st of 2017, we have optional enrollment. And to highlight what Joe said, this is really meant to provide information. A letter is going out this month, and what we want is for people not to open the letter and be confused. We don't want folks to open the letter and not have a place to turn. I've been really fortunate to work with the County Board Association, who's taken such a strong leadership on this issue, and we've had great opportunities in working with all of our managed care partners to vet this material and to really try to have information that would make sense to everyone. So let's talk about managed care. So managed care is a healthcare delivery system organized to manage cost, utilization, and quality. That's a pretty basic understanding of it, but it's straight and to the point. Currently, we have over 2.4 million Medicaid enrollees that are served by 5 statewide managed care plans. For everyone, that's 86% of the Medicaid population currently in Ohio is receiving those benefits through a managed plan that is offered by one of the five plans that are in Ohio. It's not something new. It's been around for a very long time. even today, that percentage, that population is increasing. There are other populations, such as the foster care child welfare population, that will have enrollment into managed care as well. So DD is just part of the group that is continuing the trend that Ohio has, that Ohio Department of Medicaid has, to have that Medicaid benefit managed. And again, just to reiterate, we already have 2.4 million people in the system that are receiving their Medicaid benefit through a managed plan. So Ohio pays managed care providers a fixed amount per Medicaid recipient, thus capping the total cost the state of Ohio pays for Medicaid healthcare services. This is sometimes referenced as the risk that managed care plans have, or that it's a risk plan. So not to get too much into why people want to do this or not, just those 2 bullet points that I went over. The state wants to be able to manage their benefit. They want to be able to predict what their costs are. And so what they're doing is they're inviting plans, R5 plans in Ohio, to participate, manage that benefit, and share the risk, meaning the state is going to pay them a fixed amount. So they understand what their costs are, and the managed care plans agree with extensive parameters and contracts or whatnot to manage those benefits on behalf of Ohio. The state of Ohio does set specific quality outcome measurements to hold managed care providers accountable for quality care to its members. We'll be going over that. There is a lot of material out there today. One of the things I think I would say is that as complicated as some of this may sound, and I'm not going to pretend that there isn't some elements that are complicated, I would tell you, as a person who's been in the DD system as a professional for close to 20 years now, this is very transparent. There is information that is easily found online. The state of Ohio is being very clear about what its accountability measurements are. Providers are very clear about how they're doing on it. This information is very easily found, and so I don't think there's much mystery to it. Again, it is big, it is different, but I think the states and the plans are doing a very good job of being transparent. That's my personal opinion. Moving along. So what are some of the differences between managed care plans and the fee-for-service or the state plan that's out there today? So we can all see this on the slides. Fee-for-service must search for a provider except Medicaid. Having been an SSA myself many years ago, it can be difficult at times to find a willing physician that will be part of the care or the care team for a person with a developmental disability. In managed care, physicians are assigned. I'm imagining that as part of the arrangement that physicians that are part of networks for managed care understand that they are part of that patient-centered medical home model, so that a PCP, a primary care physician, is going to be assigned. And of course, that can be changed and altered if that needs to be. But what won't happen is that you won't have a physician that's responsible or a part of your team through managed care. On fee-for-service side, you've got sort of a one prior authorization process. It's within the rules, the regulations. On the managed care side, you have a little bit more flexibility. So the process can vary, but the plans have the ability to alter how they might do prior authorization for some services, but it may vary from plan to plan. But it does offer some flexibility in other ways where the state plan is very specific, very singular, and very rigid. Fee-for-service also has any willing provider. So if the person has a Medicaid provider ID and they want to provide that service, then they're able to provide that service. Providers within the plan network, what does this say here? Providers within the plan network for most services. I guess I would say it more like this, is that the managed care plans have the ability to say, this is not a quality provider. They don't provide quality services. They do not meet our standards. And they have an ability to say that that person's not going to be in our network. So to some degree, you have a network that is being vetted by managed care where the state does not have that capacity just because of who they are and what they do. Thank you. Other differences for the state plan services or fee-for-service, you have that monthly Medicaid paper card. On managed care, you're going to see something that is much more similar to my own insurance, where I have an insurance card that's in my wallet. It's plastic, it's hard, it doesn't disappear easily or get lost. For fee-for-service, you don't have a point of contact necessarily. If you really have a challenge that's going on with your benefits, a question with regards to benefits, you might be trying to pull all the pieces and parts together, from your SSA to a parent to an advocate, who knows. But what I'd tell you on the managed care side is that they clearly have a call center, which has member services that can go through what the benefits are and different questions you might have about your plan. They have a 24-hour nurse advice line. So if there's any needs or questions with regards on a medical nature, 24 hours a day, managed care plans are required to have that as part of their call center. And of course, they have a care manager or for care coordination purposes, and we'll get into that a little bit more later. Finally, you have on the state plan the basic Medicaid benefit package. And I don't mean to reference it as basic. I guess I would reference it as what we all know today. On the managed care side, and we'll go over this later, there are some additional benefits that we would that we think are advantageous and may be of interest to some folks. So we'll go over those in a little bit more detail later. So as I said earlier, starting January 1st, 2017, individuals with a DD waiver can voluntarily choose to receive Medicaid state plan services through a managed care provider and keep their waiver benefits. This slide sort of repeats that several times, and I'm going to go ahead and read those things because I think that's critically important, and then we'll expand on that. But it does remove the need for members to disenroll from a managed care plan when they become eligible for a DD waiver. This may or may not be known. As part of the educational stakeholder groups that we've held at the Department of Medicaid, I learned that there were 7,000 to 8,000 individuals that since 2006 had come off of managed care because they received a waiver. So we may not understand this today, but there are lots of folks, and there are lots of obviously kids that are currently perhaps receiving a Medicaid benefit through managed care, that if they receive a waiver, become eligible for a waiver, they've had to come off of that waiver, or I'm sorry, they would have had to come off that plan and become part of the state plan. So they were actually familiar with managed care. They were familiar with that network, and they had to make a change if they were deciding to get a DD waiver. So that was something that was news to me. I hadn't realized how many folks probably had to make the choice. I only think about the folks that have to make the choice to manage care versus away from it. But that is actually something that's part of our system since 2006. Adult extension members can also qualify for waiver services and maintain their MCP. And again, just to reiterate, waiver services are not impacted by someone enrolling in a managed care plan. I meant to say this earlier, so I'll say this now, and that a lot of this is really, you received the toolkit earlier today, and instead of simply opening up each piece of the toolkit and reading each piece of it, we put together this slide deck to try to really address what the FAQ is saying. So if you are looking at the FAQ, realize that we are trying to pull and kind of move along that particular item of the toolkit, but we simply didn't want to reiterate it to you word for word. But a big part of that toolkit is that fourth bullet point. It's important to understand because somehow this was believed at one point and perhaps has been perpetuated and still believed by some. But waiver services will not be impacted if someone enrolls in a managed care plan. That was the whole point of the bill that we referenced at the very beginning. That is a completely different system that is monitored at the local level, is paid through at the local level, is authorized at the local level. I dare say those dollars do not pass through the Medicaid managed care budget piece. It is totally separate. It is not something to concern yourself with. Non-waiver services, this was brought up, and we wanted to highlight this, however, that there are non-waiver services, such as private duty nursing or home health, that oftentimes can work in tandem with waiver services. And it's important that we are familiar enough to understand what's being paid for through a waiver and what's being paid through traditional Medicaid. And all will be available and will be reviewed individually for medical necessity, just as it is outlined today in the Ohio Administrative Code. So nothing really changes there, but it's important to understand what is truly the waiver service and what may be augmented services through Medicaid. And then obviously if someone is choosing a plan, to understand that those services would go through that plan, and we'd want to be informed about that and understand how that would stay the same or change or be different so that we're not caught off guard. But again, to reiterate, and then I'll move off this slide, waiver services themselves are not impacted by someone enrolling in a managed care plan. That was the whole purpose of the bill, or one of the purposes of the bill.
Just a quick question.
Sure.
Adult extension member mean for the audience?
So there's a question for an adult extension member, and what exactly is that? And I'm going to say this, you caught me. This was added, and I don't know what it means. I just read it. Does anyone who augmented this slide know what an adult extension member, Jeff?
The Medicaid extension population.
Okay.
So those
Medicaid extension populations that are added through.
through the extension of the
So I'm talking to Jeff Corzine right now from United. You probably can't hear because the way the mic is set up, but are you thinking, Jeff, that the adult extension members, is that anything that we have to worry about with regards to the DD population? Would some of them go that way?
Some of them, I guess, potentially could be.
Okay. Small group though.
Yeah.
Okay. And these are just expansion groups?
These are adults, single adults, childless, 21 and up,
Mm-hmm.
who became eligible when the governor expanded the Medicaid program.
Okay. Yes, I was trying to say, could you say that one more time and then I'll try to repeat it again? They have to be older than 21,
So they're-
childless,
They're childless adults, 21 and over,
Mhm.
who were previously ineligible for
previously ineligible, but when the governor expanded,
in 2011,
Mhm.
2012, became eligible.
Okay,
Roughly 600,000 people.
so roughly 600,000 people, some might have a developmental disability, some might be getting a waiver at some point, and so for thoroughness, someone on the as I told you, managed care looked at the slides and vetted it. I meant to ask that question. So of the 208 people that are online, one of you got me, so good for you. Thank you, Jeff, for that one. Okay, moving along here. Services and managed care plans. So critical to and important to remember that managed care plans are required to cover state plan services. If you are currently receiving a service through the state plan, that service is in the managed care plan. There are no services that are currently offered that are not part of the plan. Again, we're actually going to talk about some services that are offered that are not part of current state plan services that you will see on the managed care provider, but managed care plans are required to cover state plan services. However, or just to note, managed care providers may have limitations on the amount of service, have different criteria between themselves for deciding whether you can receive a service, or have prior authorization processes that you have to go through to receive a service. That's a big disclaimer, but we also have prior authorization services today within the state. It's important to understand that as you're making this decision, that you try to understand how any of that may impact your current service needs. So, other services in managed care, and this list, just for the audience, has been enhanced. I think I know what every bullet is, but in case not, there are people here that can help on that one. So there are additional services that are covered through the benefit if you choose to go through a managed care plan. As we referenced earlier, there's a permanent member ID card. There are incentive programs. I'm not sure how that may or may not impact an individual or a provider or a county, but if there's a question about that now, we can try to get to that or answer it later. But there are incentive programs. There is enhanced vision and dental. Oh, did you have something, Chris?
I can jump in if you
Oh,
like.
well, sure. Hold on just a second. We have Christine, correct? From, don't tell me, from Molina. Oh, you had to tell me. So here's Christine from Molina to answer some of that.
Okay. Good afternoon, everybody. I'm going to just pick up here with the incentive programs. Each one of the 5 managed care plans has different programs. One may be pregnancy rewards, where we're incentivizing women to go to their OB-GYN to make sure that they're getting their prenatal care so that we have a healthy baby. Others, too, are incentivizing children to go to dental visits and all of their well checks, again, because we're looking for healthy outcomes. Enhanced vision and dental, the plans do cover biannual dental visits for cleanings, x-rays, and basic preventative care, and then also enhanced vision. We do provide annual vision checks for children and adults. Transportation is a very nice enhanced benefit that all the plans offer, and again, it does vary by plan. Some may pay up to 31-way trips or 15 round trips or 31-way trips by van or cab, whatever the member needs. If it's a person who's requiring chemotherapy or dialysis, those transportation limits are waived, and the member will get them. Get the transportation benefit regardless. We also have a call center that is manned 5 days a week. Most plans have it till 7 o'clock at night, so that providers and members can call in for any benefit questions or assistance. We all have a 24-hour 7 nurse advice line, which is manned by registered nurses, and that's 24/7, 365 days a year, so that folks can call in and get medical advice. They're certainly not there to direct care, but they can certainly answer and field any questions that the member may have. We also care coordination piece, which is probably the most important benefit that we feel that we offer, because it allows the member to have somebody on the plan side to help coordinate their care, in addition to any case manager or care coordinator who's in the field. And we'll go into that in a little bit more depth shortly. Disease management programs include diabetes, smoking cessation, asthma control measures. All of these are free and part of the benefit plan. And then lastly, transition to fee-for-service, or from fee-for-service to a managed care. All plans offer a 90-day transition period to help the member transition into the managed care plan. Their benefits will not change from the fee-for-service during that 90-day transition period. All of their providers, their medications and everything stay intact. At the end of that 90-day period, then we would hope that we could transition them into a in-network provider to where they could get ongoing care needs.
Good. Great. Thanks, Christine. We'll hear from her a little bit more. Just at the end, we're going to be doing, or near the end, we'll be doing some case study review. Matt is here from Guernsey. He's an SSA. I'll be talking about a couple scenarios, and Christine's going to help kind of talk about how a care coordinator might interact with an SSA based on those scenarios. So I think that's going to be very helpful to everyone. That's another one of the big questions, just care coordination. How does it work with an SSA? I also want to just highlight that last point. I think it's critical, the transition plan, to cover fee-for-service benefits approved prior to managed care, that transition plan in general. The state has identified that for all the transition populations, so we're talking about kids in foster care, we're talking about folks on the waiver, they have an extensive history and experience and are currently receiving medical intervention or treatment. The state has afforded for that transition to be noted, to be identified, to make sure that none of that, regardless if they're in a network or out of a network or whatever it is, that is taken care of. It's not forever. I think you said 90 days? Yeah, 90 days. So again, if there's some concerns about that, I think the state's done a good job of highlighting and saying, yes, we know we don't flip a switch and suddenly just change everything. And the plans will be there to work with you, make note of all the needs and the treatment that's going on, and kind of move from there. So a great benefit. Thanks, Christine. Okay, network and other considerations. So it's important to note some of these elements. Managed care providers are required to demonstrate network capacity each quarter. So all the professionals that make up the network, the primary care physicians, the specialists, the dentists, the psychiatrists, whatever you can think of, the managed care plans are required to demonstrate their network capacity each quarter, and it is based, of course, on the size of their network and how many members they have. Now, I'm going to kind of pitch hit here and say that I believe if you look at the contract, as I continue to say, things are very easy to find out on the internet. Everything is very transparent. Managed care providers are held to high standards with regards to primary care physicians. There's not the same kind of requirements necessary for psychiatry or for dentistry, but I believe this population, the population who has a developmental disability, has been highlighted that managed care providers do need to make that consideration and understand that these populations need to have adequate networks of dental or psychiatry. I'm going to look at my managed care folks if I'm saying anything out of line. They're all shaking their heads. Okay, so thumbs up on that one. All right. It's important if you're going to do anything to help a family or an individual make a decision to move into a managed care plan, check the networks. This is probably the biggest thing we talked about early. That information is on the websites of the different providers. We've got some different links at the end of the slide deck that I think will be very helpful to understand and find whether or not your dentist or the person's physician or specialist is covered in their network. That would be a critical thing to do. Certainly look at the Medicaid Managed Care Report Card. The toolkit does have that particular slide is in the toolkit. It's something that's done every year. You have the 2016 report card. It's a very easy snapshot. I don't want to say it's immensely detailed, but certainly tells you how folks are doing in areas that the state are asking about. Those things are, again, easily found online through the Department of Medicaid, very transparent. The Department of Medicaid puts an annual report out and has a whole section on managed care in there. So again, lots of ways to educate yourself at this point and help folks on your caseload make good informed choices. And the last bullet here is to make sure you understand the voluntary enrollment and disenrollment process available to you. So this was a little, this wasn't clear to our little group that helped put these slides together initially, but we've been able to get further understanding on this. And I got to tell you, I was very pleased, quite honestly, from what I heard. So we all understand that a letter for enrollment is coming out. We all understand that folks that are on the waiver will receive that letter, or their families will be with them to receive that letter. And it talks about enrollment, what that process is, and we're going to have someone from one of the, I think Paramount is going to step up and help on that one when we get to that slide about just sort of the general aspects of enrollment. But I think it's critical to understand that, again, the Department of Medicaid on disenrollment, listen, it's not going to happen overnight if someone changes their mind. But what was very good for us to hear at the County Board Association is that if someone does enroll and within a couple of months, even a little bit longer, really feels it isn't working out for them, they have the ability to disenroll. It's not going to happen overnight, but it's like somewhere on the south side or north side of 30 days is kind of what I'm being told. And we got that right from the Department of Medicaid. I think that is a really important thing for people to understand. Change is never something people embrace easily. But if the risks are mitigated in the sense that, you know, if this didn't work out, I guess I can always go back to it. As we understand that today, that would be available. So I think that's really critical to understand in the decision-making process. Okay, a couple questions. All right, I'm with Christine again here. So the first one is, will adopted children be eligible to enroll in a managed care plan through a provider now?
Okay. Yes, in November, which is our open enrollment period, the adoptive families will be able to, they'll go through just a traditional enrollment, and families will be able to select a managed care plan at that time. And then they would be effective in January of 2017.
Great, thank you. And the second question, if a person enrolls in a managed care plan, does their annual redetermination with local JFS work the same way?
Yes.
Okay, Jeff is saying yes, and the other, yep, we get a yes on that one. So, survey says. Okay, what do we got? All right, moving along here. All right, so this is the part. I think we're doing a good job on time here, and this is the part. I'm going to step away a little bit here. I'm going to bring Matt in from Guernsey County. He's going to read a couple of examples, and Christine, I'm going to let you kind of take this spot. I think it'll be easier.
All right, thanks, Chris. When somebody enrolls into, their managed care plan, if they choose to do that, they'll be assigned a managed care plan, a care coordinator, or also, called a case manager. So once they're enrolled, they get assigned their case manager. I'm just trying to determine what the difference is, or what the role differences are between a case manager, a managed care case manager, and an SSA. So we had a couple examples that came up. One example that I've actually run into is I had an individual who was ordered a pureed diet with nectar thickened liquids. And this was a new diet to him. He wasn't used to it, and he didn't really enjoy it. So for his quality of life, I contacted his physician and a speech therapist to clarify if this individual could have, like soft food, such as like a cupcake that he could eat just, to improve his quality of life and give him some enjoyment. So they agreed that this is something that is doable for him. So the physician wrote an order stating that he could have a cupcake or soft foods. He just had to eat it with supervision. So as an SSA, I just went ahead and obtained that order myself. If he has a case manager or a care coordinator through managed care, when I get an order like that, is that something that I have to share with the case manager, or do I need to call them and just tell them, hey, this is where we're at with this individual and we would like to obtain this order? Does the role change for the SSA, as far as obtaining orders for that?
No, this is Chris from Molina. No, there wouldn't be any change. And actually what the state has asked the managed care plans to avoid is any duplication of services. So the care coordinators in the community would still continue their same role. There's not going to be any change there. What it would be on the managed care end, though, is for that case manager to help the SSA to navigate the insurance plan's benefits, providers, and those kind of things. Let them know if any items require prior authorization, just so there's not any gaps in care.
Okay. All right. And then the other one that came up, I had another individual. He's a diabetic. He went and had some lab work done, so his A1C came back elevated. His physician wanted him to have, home health come into his home just to assist him with his insulin injections and to make sure that he is taking his insulin as prescribed. So the physician, he sent an order to me stating, hey, this individual needs home health. Would you set that up for him? So in this situation, would the managed care provider need to coordinate that, or would the SSA need to refer the physician to the managed care plan and say, hey, these guys are now taking over this? I mean, can I still continue this, or is that something managed care would have to do?
No, that would still be your job or your role rather. The provider would then submit a prior authorization to the managed care plan for home care services, and we would take care of that end.
Okay. Then how about if I had an individual that was coming to school and he just needed to have some medical equipment brought to school, like a humidifier for his trach? Would I contact you guys to do that also, or is that still something that I would just do on my end for medical equipment?
You would talk to the physician. The physician would then need to contact us for the prior authorization. And some equipment doesn't require prior auth. It depends on the plan. But again, your role would be pretty much the same. The provider would just be responsible for contacting us for the prior auth if necessary.
Okay, so if I do get new orders for my individuals, I don't necessarily have to contact a managed care plans and say, hey, I have orders for my people. You guys, it just automatically goes through you guys through the physicians.
Correct.
Okay.
Correct. And then the case managers would be working closely with you just to, coordinate the care and, again, make sure that there's no gaps in care.
Okay.
Yep. Did you want to add anything?
Let me throw in, just to be really clear, too, because we use the term provider a couple times in there, and I know what Christine's meaning is the physician, the home health company itself. These are all folks that are probably most likely in the networks already. And so they understand the process. When an order comes in, they're verifying. As I said, this is like insurance. It is insurance. And so they're going to doing that same process that you'd expect your physician to do before they do tests for you. So that's the provider network, not necessarily the DD waiver provider that she's referencing there. Great, thank you. You want to go ahead and do questions? We've got just a few more questions. I'm going to read them out here. Some of them are just to reiterate what I said, and I'm going to continue looking at the. You can have a seat. Yeah, go ahead and have a seat there. So right now, it says here, right now it's going to be optional. When will this be required that families/individuals enroll in a managed care provider? We have no idea. I think that's the best way to say it.
No plan.
There's no plan currently. That's a better way of saying it. Thank you, Joe. Yes, there are no plans currently for that to happen. This is optional enrollment. That's really all we can speak to, I think, at this point. Number 2 and 3 are kind of similar questions here. If an individual voluntarily enters into a managed care plan, do they have the option to disenroll and go back to regular Medicaid? Based on a conversation that Joe and I had with Patrick Steffen from the department, yes, they are capable to disenroll. They are held harmless, if you will, to any kind of, if they decided to change their mind, they can do that.
Can I add to that, Chris?
Yeah, hold on, Joe would like to add.
Yeah, and just to add a little bit more level of detail, the way that it works is if a person was to choose to disenroll, they would call the 1-800 number available for enrollment to make that process begin. But depending on the date, the actual disenrollment wouldn't occur until the last day of the month. So if let's say that you disenrolled today, then you would continue on with your managed care benefit until the end of the month, and you would transition back to the Medicaid card services. So there is a little bit of delay. We do want to also state that it's probably not a good idea for people to be enrolling and disenrolling on a regular basis. We really want to make sure that this is the choice that they want to make. Of course, if they have issues with the plans, we really encourage people to work with the plans on any of those issues before making the decision to disenroll. So just wanted to add that level of detail.
Thanks, Joe.
Wanted to talk and add just a little bit more to how the optional process is going to work. So we mentioned that there's going to be a letter sent by the Department of Medicaid that's going to inform individuals and families of this option to enroll. There is a copy of the letter as part of the toolkit, so you'll know exactly what that looks like. I do want to point out that it might look a little bit different because there's going to be addresses to the individual and also return addresses and whatnot, but the content is the same. We took out the mail merge links because it was sort of confusing and ugly, but you can take a look at that letter. We really encourage you to read through that. And please reach out to us and ask any questions you might have that's unclear. Again, it's really easy to enroll. You're going to call that 1-800 number, and that's how the process begins. The SSA themselves are not going to be involved in that enrollment process. You're simply going to navigate any questions that you might receive from your caseload. And again, you may not receive any questions. But your role is simply to, or at least what we hope is that you'll have the information that you need to answer those questions. But again, don't feel like you're alone in this. The state can help. We have the consumer hotline, and of course, the Department of Medicaid's website is very, very helpful. So the letter will go out later on this month. Families will start receiving it by the end of the month and throughout towards the end of the year. So you could receive questions by the end of this month. You may not receive any questions till November or even December, and even past that. So we want to make sure that there's information available at any time that you need that. And I also want to point out that in the toolkit, you have specific contacts that were provided to us from the managed care plans, direct phone numbers and email addresses, primary and secondary, their website. So you really have a lot of information at your hands that you to navigate some of these questions. So with that, we wanted to open up for questions and answers. We've answered a few questions that we've received, but we'd like to just offer an opportunity for people to ask any questions that they might not have asked yet. Adam, anything? Awesome. Okay, so question is, DOD approves PDN and state plan for those previously on a TDD waiver through a nursing assessment that the SA submits. If the individual goes to a managed care plan, that approval then goes, does that plan then, sorry, back up. If the individual goes to managed care, does that approval then go through the managed care plan? Jeff Corzine is going to answer this for us, and he's coming up to the microphone, so just give us one brief second.
Good afternoon, everybody. You'll have to look at the service that's being provided. If that PDN service is being provided under the waiver, then the SSA would be responsible for arranging that service. If the PDN service is to be provided under the state plan, then you'll work with the health plan care manager to arrange that service. So you always have to look at the funding source, essentially, to determine who's responsible for ordering the service.
Doesn't it fall, I know they can't probably hear me on the microphone, but in the order of who pays first, isn't it the state plan before the waiver?
Yeah, the follow-up question was, what's the order of responsibility? So generally the state plan pays first, and then if state plan service is not available, then the waiver service would be the governing responsibility.
Couple more questions. First, are care coordinators able to close cases due to a lack of a response, etc.?
Well, care management is always voluntary, so we can't force anyone to be under care management. The state asks us to stay involved to the extent that we can. So we do have telephonic outreach. All of us now have community health workers as well as field-based care management staff. So we continue to try and stay engaged with the member, even though we may not formally have a formal care management relationship. And we would also stay engaged with the SSA so that we could indirectly continue with some type of integrated care team for the service of that individual.
Perfect, thank you. The next question has to do with the nuances between the waiver and optional enrollment. The question is, do you have to be on a waiver in order to have the option for enrollment? In other words, if you're an individual with developmental disabilities that is eligible for county board services but not enrolled on a waiver but eligible for Medicaid, do you have the option to not enroll in Medicaid managed care and just keep your fee-for-service Medicaid?
In general, no. For individuals who are on the waiting list, you're considered to be on regular Medicaid, and therefore you're already enrolled in a managed care plan. So you fall under the mandatory enrollment requirements. So there are a number of people that we serve today, both adults and children, who are currently served by a managed care plan.
And are served by county boards.
And served by county boards.
Checking the roll here for more questions. Just a second. Another question, can an SSA bill TCM if an individual is on a Medicaid managed care plan?
So I'll have to ask, is TCM a billable waiver service or?
Targeted case management, it's unique to county boards, it's a Medicaid coordination type thing.
I think we'll have to check with Medicaid and DODD to see how they want that handled. I don't have a good answer for you.
We'll star that one for follow-up and we'll get some answers for you. Next question, is payer sequencing going to be continued as state plan then waiver? What keeps the managed care plan from denying to reduce costs, then the cost shifting to waiver, thus to county boards?
That is an interesting question. So for the first 90 days, the person is enrolled with us. We're not touching their care plan or their services. That is a state requirement. So we will be using that time to work with you to determine what the best set of services and supports are for that individual. And we will simply follow the state plan requirements as well as the waiver requirements. If it's to be a state plan service that's covered, we'll pay for it. If it's covered under the waiver, then the waiver pays for it. For the information that we've been provided by the state, the waiver services are pretty cut and dried in terms of what's covered, and we would use that as the benchmark to determine whether or not something is state plan or waiver service covered. So I don't anticipate there'll be any differences in what happens today. I mean, if that kind of cost shifting happens today, it already happens today in the fee-for-service world. I actually think that there's greater accountability with managed care because there's greater transparency.
Thank you. Next question. Will individuals in ICFs be given this option as well?
So folks that were enrolled that are living in an ICF have been exempted. There are roughly 5,000 individuals statewide. The feeling was from Medicaid that ICFs have similar care coordination requirements that health plans do. And so in order, if they were to be enrolled in the managed care plan, it would be a duplication of effort. So the Department of Medicaid chose to keep them carved out of managed care as they are already theoretically in a managed care environment.
When the managed care company denies a service, do they give the individual due process rights?
The answer to that is absolutely yes. The individual has a number of options for appeal, both through the health plan and through the state hearing process. So generally the ask is that you avail yourself of the health plan's appeal rights, and once exhausted, then you have the right to file a state appeal if we haven't either reversed or if you don't like the results of the appeals, the conclusion of the appeals process.
What about folks that have their Medicaid through the buy-in program that are on a waiver? Will they have the opportunity to go to a managed care plan?
My understanding is that buy-in recipients are still carved out, that's a separate program, and they remain in traditional Medicaid.
I have a question, or at least wondered if there was anything that you guys could share with us in terms of any conversations or developments related to early intervention. This is an area that a lot of our county boards participate in. We've been hearing that there might be some interplay with the managed care plans. We wondered if there was any updates you could provide us.
To date, we've not had any discussions around early intervention processes. We're assuming that will be probably some of our next steps with the board association and the counties to discuss what that might look like.
Okay, we have another question. Will the county board be given notice of the denial of service, or will we have to get that from the individual who was denied?
So typically, the service denial notice will go to the member or the authorized representative of the member. So this is probably one of the areas that we can work on together to determine, because we're actually going through this process now with children in care and who's identified as authorized representatives and who we can speak to. I have a feeling we need to have that similar kind of discussion with you all. And so there are certainly ways for us, if it makes sense for those denials to go to the board or to the SSA. Actually, if the integrated care management process works like it does, the SSA will know in advance of the actual denial issuance that a service has been denied, so we can actually plan for that. And hopefully with the integrated care team, we actually avoid those denials because we're working together to best coordinate care to minimize that kind of result.
Thank you, sir. Many individuals who fall under case management only, so those who do not have waivers but receive SSA services, are on Medicaid managed care plans. If they receive a waiver, will their Medicaid managed care plan follow them, or will they have to go to Ohio Medicaid and then re-enroll in a managed care plan?
So my understanding is today that their managed care plan will follow them. If, however, the state determines that a re-enrollment process is necessary, the end result will be the same because there's a 3-stage algorithm that comes into play when someone enrolls in a managed care plan. The first thing the algorithm looks at is prior health plan enrollment. And so if the person has been enrolled in the health plan in the last 6 months, the state will auto re-enroll them to that health plan. If that piece of the algorithm can't be met, the second stage of the algorithm is to look at providers within the health plans and match them up to providers that the individual is using, and they select the health plan based on the most number of hits of utilized providers. If those two steps of the algorithm don't work, then it's a round robin assignment to one of the 5 plans based on the quality scores of that health plan. But in the scenario you just gave, in all likelihood, the health plan will follow the individual once they move into the waiver.
All right, we're going to keep this rolling. If a person is in a managed care plan and wants to enroll in the Medicaid BuyIn program, will they have the option to enroll in the Medicaid BuyIn?
I think that's a question we'll have to Medicaid to ask. My thought is yes, but I honestly don't know. So I think that's a great question for us to pose to Medicaid to see how they want that treated.
Will there be any changes in the way that we monitor PLOMs, the cost of care?
I don't believe so. I think obviously as we develop our integrated care teams with one another, hopefully we add some value to you as you look at how you're costing out your waiver costs. But since we're only responsible for the cost of physical health care, I wouldn't anticipate any changes in those activities that you have to carry out as the overseer of the waiver in your particular county.
If the county board is if the county board is the authorized representative, will we have to set up that with the managed care plan, or will they have that information from JFS?
That is another procedural question that we and the board will need to take to ODM. We've had a very similar discussion with them around children in foster care. This probably warrants that same kind of detailed discussion to see what they're going to provide us on that HIPAA 834 enrollment transaction, and whether or not they give us either the board or the SSA at the board. And I don't think we haven't gotten into that detail with Medicaid yet. So certainly I think these are great questions for us to start to compile and take back to our next joint meeting to see how they want to handle that.
Absolutely. And just so you're all aware, we've been meeting now since I think December of last year. There's the Department of Medicaid had convened a work group that's comprised of several DD stakeholders, as well as all the plans and folks from the Department of DD, as well as Department of Medicaid. We've had a number of meetings. They've been really great. We've been going through looking at rules, and we have another one in November. So we're going to continue the progress that's been made and continue to look for collaborative ways to work together. We have another question. State plan services will pay for things like a motorized wheelchair every 5 years. Are there any differences in time span for these types of medical equipment?
We generally follow the Medicaid fee-for-service timeframes on things like durable medical equipment, especially for motorized wheelchairs. I will say one of the things that can happen as you're working with a health plan care manager is if we collectively spot a need for a replacement of a chair before that 5 years, as health plans we certainly have the ability to not stick to that 5-year time limit. And I think Medicaid tends to be a little more prescriptive in their time frames, where we have the latitude to be a little more flexible in how we look at that. But we're going to base it on medical necessity and patient need.
In our discussion, it was mentioned that individuals can automatically receive case management when enrolling on a managed care plan. As an SSA, I've had many families of individuals who say that they have never spoken with a care manager and cannot give any information on them. How would they find their care coordinator's contact information?
So I may rely on my colleagues behind me, but When we outreach and develop a care management relationship, the care manager will actually provide direct contact information so that the family or the individual or authorized representative will know who their care manager is from the health plan, how to contact them, either by phone or by email, and the methods by which they can be contacted. And that may vary a little bit from plan to plan, but generally, that all of us will have ways and are obligated to make sure you know who your care manager is.
Could you also call the call center?
Yeah. So from a United standpoint, you can always call on the back of the member's card. There's a toll-free member service number. You call our member service number, ask for our care management department, and that will ring you into our care management department. You just tell them who you are, and they will find your care manager or identify your care manager and connect you, if able. If not, certainly will assist you, and then reach out to your care manager to make sure that they're going to call you for your request.
And this is an area that we've been talking a lot about, and we're going to continue to monitor. And if there are special needs with the county boards and the SSAs contacting care managers or whatnot, we'll definitely work collaboratively with the plans to sort through some of those issues. Questions keep rolling in. This is awesome. Thanks, guys. Will the managed care plans help coordinate Medicare Part D for individuals who are dual eligible?
So for those individuals who are dually eligible and not enrolled in a waiver today, and live in one of the 29 MyCare counties, they have the option of voluntarily enrolling in the MyCare plan, where both their Medicare and their Medicaid services would be paid for and coordinated by the health plans that are available in those counties. If they're on a waiver and they're dually eligible, I have to admit I'm not sure if they'll be required to enroll in a managed care plan because of that dual eligibility. We'll have to take that question. I don't know. I don't know if they would enroll in the plan for their Medicaid services only. It would make care management and coordination of services quite interesting, because the managed care plan would not have line of sight into the Medicare carrier. So it creates some unique nuances that we would have to work through, but I'm not sure what the department's thought was in that particular instance. So probably another great follow-up question for us.
Absolutely. And you had mentioned that you serve part of the state. You said 29 counties, I believe. Is there anything you can say about expectation of when it might move to statewide-ness?
The director has indicated at the end of the demonstration that they will be looking at ways to extend the program statewide, maybe in its current format, maybe not. I think those are things that they're looking at from a programmatic standpoint. If that happens, I'm going to guess it would be 2018, 2019, 2020 in that area before they would consider or as they think about moving that MyCare program statewide.
Awesome. We have another question here. What is the typical caseload size for a managed care plan case manager?
So we have specific requirements for Medicaid for our caseload sizes. For intensive, it's 1 to 25, 1 to 50 now. So for folks who fall into what we call the intensive level of service, where they need to be seen by a field-based care manager once a month, the caseload requirement max is 1 to 50 maximum, so 0 to 50. If they are moderate, it's 1 to 100. Our moderate level of management is 1 to 100, and then low or monitoring is 1 to 250. I think it's 1 to 250, but the average size, so a case manager is going to have a mix of intensive, moderate, and monitoring members. I think it works out generally to be between 50 and 75 members on average.
And just I wanted to touch on one thing you just mentioned as the term member. In a managed care plan, each person is considered a member, which is kind of nice because you're treated like a member. It's not just, you're not a customer or a guest, you're a member, and that's an important aspect of the managed care plan. Next, how will all of this fit into the Medicaid changes with dropping Medicaid for dual eligibles and only covering QMB?
You've stumped me. I guess I need a little bit more information to be able to answer that question for you.
Well, there's another question on dual eligibles, but we'll mark that star that one to follow up on. But back to the question about dual eligibles. Do you have an idea which counties are not involved in MyCare?
Yeah. So there are 29 counties currently in the MyCare service area. So that's 71 counties, 61 counties that are not. The counties that are generally fall into the 7 major urban areas and the counties immediately contiguous. So Hamilton County and 4 counties immediately contiguous, Franklin County, 5 counties immediately contiguous, Dayton area with 3 counties contiguous, Toledo with 4 counties contiguous, Cleveland with 5 contiguous counties, Akron, Canton, 4 counties there, and then Columbiana, Mahoning, and Trumbull counties as the 7th area. So everyone else is status quo. So if somebody is dually eligible, then they are in fee-for-service Medicaid today.
All right. Well, that looks like the extent of the questions we received. I really appreciate the time and thought put into this. I do want to just mention that we're going to be meeting, as I mentioned, with our broader Department of Medicaid stakeholder group in November, and we'll be able to bring some of these questions to their attention then. So we're, as we mentioned at the onset, we're going to be compiling all of these. We'll be choosing the ones we've starred and any other ones that we need to go through a level of detail. We're going to continue to work collaboratively with the Department of Medicaid as well as Department of DD and the Medicaid managed care plans to kind of sort through some of these nuances. We don't necessarily expect everything to run perfectly, but these folks have a lot of experience, and again, I think the focus of our attention is just to ensure that the people that the county boards serve can live a higher quality of life. So with that, I'd like to thank everyone for being here with us today. I'd like to thank all of the managed care plans for participating. I want to thank our internal work group, Chris and Matt and Adam, for making this all work today. Give a shout out to our small work group, especially Lori Chick. We really appreciate all the help and all the effort that's gone into this. So thanks again. And remember, if you have any questions, please feel free to reach out. Thanks.